computer. There you go.
You want to pin me? So, hi, everybody. I'm Dr. Robert Amajoy. I'm a colorectal surgeon here in Kansas City. I'm the director of rectal cancer program at St. Luke's Health Systems and the current president for the Society of Black Colorectal Surgeons. March is Colorectal Cancer Awareness Month, and welcome to this round table. It is an open forum. Today, joining me are three esteemed, very busy colorectal surgeons, all in private practice, by the way, who's taking time out of their busy practice today to come and talk about colorectal cancer. Joining me is Dr. Lynn O'Connor, who's colorectal surgeons extraordinaire in New York City. She's a president of the Colorectal Surgery of New York, and she's the chief of colorectal surgeons at Mercy Hospital. Welcome, Dr. Lane O'Connor. And also joining me is Dr. Godwin Ofiku, who's the president and owner of Colorectal Surgical Associates of Nevada. He's assistant professor of surgery, University of Nevada School of Medicine. He's also in private practice. Welcome, all the way from Nevada. What time is it over there now, Dr. Ofiku?
It's 7:34.
Wow, you woke up that early, huh? And the last but not the least, Dr. Erin King-Mullins, who needs no introduction. Dr. King-Mullins is the president of Colorectal Wellness Center in Atlanta, Georgia. She's also very busy, a social champion for colorectal cancer. You should go to her Twitter account. It's called Get Screened. She's been an inspiration and talks about colorectal cancer. So you guys have three prominent surgeons here to talk about this with you. Let's welcome them all. So as an introduction, I want to talk a little bit about colorectal cancer because I have our first commenter here. Colorectal cancer is common. It is deadly and is very, very preventable. It is the third most common cause of cancer in both men and women. It is the second most common cause of cancer-related deaths. And even though it is very preventable, still yet, only 1 in 3 adults have been screened. So let's have Dr. Lynn O'Connor come in. Dr. O'Connor, what is colorectal cancer? Because everybody, it's not something that is a everyday discussion or everyday word, actually.
It really isn't. And it's something that, I'm glad my colleagues and I are here to spread awareness about. And like you said, it's the third most common cancer, but a lot of people aren't aware of that. We're more familiar with breast cancer. We're more familiar with lung cancer. But March, being Colorectal Cancer Awareness Month, is the opportune time to inform people about the risk of colorectal cancer and screening. And colorectal cancer really is just normal tissue in the colon that continues to grow and grow and grow. The mechanisms for the cells to stop growing are impeded. So this tissue, which goes from a small polyp to a large polyp and eventually a cancer, and then the blood supply to that cancer is outgrown, and then it breaks off, and that's how you get metastases, which means those cells spread to other parts of the body, such as the liver and such as the lung. So we recommend screening early because we can get that growth before it becomes a cancer. You can remove that polyp, and thus removing that polyp, you can affect an early cancer, which has a greater chance of cure. 95% of people who are stage 0 or 1, 5-year survival. But if you wait and you don't get screened and it has grown, your survival decreases. So that's the importance of getting screening and for colorectal cancer awareness.
Very good. So that's a very good comment there and a very good description. Dr. Erin, is colorectal cancer a man's disease, and does it only affect older white people?
No, and that's an awesome question. One of the things that I commonly see is, a male patient comes to see me and he's like, yes, my wife, has been hounding me to get my colonoscopy, and she may be there with him. And I look at her and I'm like, have you had your colonoscopy? And she's like, no, I'm a woman. And then I'm like, no, no, no. We all have colons. And so, when we look at statistics, while there is a slightly more male predominance and preponderance for this cancer, it affects us both. Okay, men and women have colons. And when we look at the different statistics, people tend to separate the men and women, right? And so while the colon cancer may be a little bit further down the list, maybe like more like the fourth most common type of malignancy or cancer in women, third most common in men. When you combine both groups together, it is the third most common cancer and the second most common cancer death in the country. And so that's why it's important that everyone is at risk.
I'm very glad you mentioned that, because I've been in practice for about 10 years, a whole decade, and just about every single time, folks still think it's a man's disease, and it cannot underestimate that. So everybody know that if you have a colon, you can have colon cancer. Thank you, Dr. Aaron Akingwale. Dr. Fickle. So you in private practice down in Nevada, I'm sure you see a lot there. Is colorectal cancer preventable? And do you think it's curable?
Yes, very much so. Thank you. Colon cancer is about one of the cancers that is 100% preventable. We know where it comes from. It arises from polyps. Though we have other pathways, but as long as we keep with screening, we can prevent it. So there are different ways of prevention of colon cancer. The most important thing is knowing that the colonic mucosa has no polyps or abnormalities or lesions. And how can we see that? How can we know that? We know that by getting colonoscopy. A lot of people think that colon cancer has symptoms. I call colon cancer the great mimicry. It has no symptom. It just mimics other things that are common symptoms in the society, like hemorrhoids. You see blood, people see blood, they think it's hemorrhoid. Diarrhea, abdominal discomfort, just bloating, different things. So it on its own, it has no symptom. And so one needs to have high index of suspicion. You can see people for the first time and they have colon cancer that has been growing for a very long time, especially those on the right side of the colon. Even if it was bleeding before that comes in stool, it's already mixed with stool, so you don't see anything. And the first time people may present will be when they either have lost a lot of blood and all. So yes, colon cancer is highly preventable. We started initially by saying, okay, let's test blood in stool with occult blood testing. And we realized that that is also not very sensitive. That kind of test is not very sensitive because there's so many things that can give you blood in stool and gives a lot of high false positivity. Then we now say, okay, let's use some other immunochemical testing in addition to that. And even that, though it's more sensitive than the occult blood, it's still didn't catch everybody in. Perhaps the most important leap in testing for colon cancer came with introduction of flexible sigmoidoscopy when we started combining it. But that is only the left side of the colon. And subsequently, because of the success of that flexible sigmoidoscopy, it was extrapolated to say, okay, wait a minute, if we screen the entire colon, then we would get everything. And so we now started with colon cancer screening by colonoscopy. And currently, there are other screening modalities like Colorectal test, which is based on DNA, fragments of malignant cells in stool. That is also very sensitive. However, like I tell people, it is geared towards being highly sensitive, less specific. And so there are some high false positives as well. You want to have that because you don't want to miss anything. But by far, the greatest bank for money is colonoscopy screening, where we visualize the mucosa of the colon and we see even before little um, other lesions may come up that are not polyps. There are different pathways that people can get. The non-polypoid pathway the colon cancer may arise not exclusively as a polyp, or even if it does as a polyp, the growth doesn't follow the normal pattern. So if we do see those and we take biopsy, we'll know exactly what they are and we know how they behave. It is said that if you can name something, you know it and you can prevent it, you can cure it. And so that is the screening aspect of it. But wait a minute, even if you try to prevent it and you miss it, colon cancer is one thing that even when you catch it as an early stage, as Lynn was saying, it is still completely curable. Yet it gives us such a redundancy, a time lag for us to cure it compared to other malignancies that you just need to present yourself either as a primary prevention or a secondary prevention uh, level. Because if you have a polyp or even if you have an early cancer, we can still cure it. Even at this point, if you get to a stage 3 cancer, we're still aiming at cure. Initially, we used to say, okay, when you get stage 4, that's it. But even now, we're pushing the boundaries to say, even at stage 4, we can still try to aim for cure depending on the biology. But by far, the greatest thing you can do is to prevent. Present yourself for colon cancer screening. The age difference, and I want to emphasize this, for general population who have no risk, the age of screening is 45. For African Americans, that age is not 45. I would advise an African American person to screen at age 40, not 45. And so age 45 is for everybody. Those who have family history of colon cancer, their age is not 45. It starts with the age of what was the age of the person, the relative who had colon cancer. You want to screen 10 years before that age. So that age is not 45. Also, for patients who have other diseases, Crohn's disease, inflammatory bowel disease, for more than 8 years or 8 years or more, their risk is higher. It's not like the general population. And the mistake most people make are putting age 45 for everybody. So I want to emphasize age 45 is for general population, average risk, whose risk are not higher than the average population. And there are a lot of people who fall in that category.
Wow, that's a lot there, Dr. Ofeku.
Dr. Rob, if you don't mind, because I do see there's some new listeners that are coming on. Welcome. Thank you to joining this forum. I want to just take 1 minute of pause and put things in perspective. You know, Lynn and Godwin made some great points about, you know, how the colon cancer starts as a polyp and then it eventually grows and, you know, what we can do to prevent cancer and to treat cancer. But you know, some people are really just not really understanding what a polyp is, you know, and kind of when we talk about growing, what size dimensions are we really talking about? And so, you know, when we're talking about screening, as long as someone's colon is cleaned out well, and I think we'll talk about preps and stuff later, when we do those colonoscopies, we can see polyps as small as like 1 to 2 millimeters in size. We're talking about exquisitely small. um, when do we start really getting concerned about cancer? So once a polyp reaches about 1 centimeter in size, And 1 centimeter is like less than half of an inch. Again, trying to put perspective on things. Once it reaches 1 centimeter, there's about a 50% risk that there's cancer cells on the inside of that polyp, right? And so something that small is not going to cause a blockage, really bleeding or obstruction or symptoms. And so the number one symptom, quote unquote, of colorectal cancer is actually no symptoms. So that's why we're being, so aggressive and having these conversations and really wanting to put things in perspective for people to understand where the risk comes from and why we actively have to go look for problems.
And the other thing that's extremely important is even before you get to your screening colonoscopy, it's important to adopt a healthy lifestyle. And that
Yes.
healthy lifestyle is going to include a good diet, diets that are high in fruits, high in vegetables. You want low on saturated, the saturated fats you want to avoid, the McDonald's of the world, the Taco Bells, not to call them out. But I always tell my patients everything in moderation. So if you are going to indulge, you're not indulging every day. It's important also to make sure that in addition to that high fiber diet and the Mediterranean diet, that you're exercising. We have a sedentary lifestyle. We can Uber eat, we can do everything from the touch of our smartphone. So we need to get out, we need to exercise. Something simple as just gardening and dancing. It doesn't have to be a major CrossFit session. Even if you break it up to 10 minutes a day, within 3 times of that day to get a good 30-minute exercise. And studies have shown that people who have had colon cancer that has not metastasized, they've had surgery, and they exercise, they can decrease their risk of recurrence. And just exercising in addition to that decreases your risk of colon cancer. So eating right, exercising, decreasing the amount of alcohol. Usually it's 1 glass for women, 2 glasses for men. Studies have shown now it's 1 glass a night per day for people if you are going to indulge. Obviously, smoking of any kind, whether it's legal or illegal, is absolutely prohibited if you're trying to prevent colon cancer. So adopting a healthy lifestyle and reducing those risk factors and making sure you are screened, you are active, you are eating right, you are exercising. And if you do find something that's wrong, such as a change in bowel habit, such as a little bit of blood, such as making sure that you're getting full, you're feeling constipated, those are signs and symptoms that make you think, let me get checked. And those are also a lot of the things that you can do to even prevent the colon cancer in addition to getting screened.
So I want to put a spin on what Lynn just said. So
He's muted. We cannot hear you.
yeah, sorry. I wanted to put a spin on what Lynn just said. People may be wondering, how are these things getting sedentary lifestyle? How are they involved? How do you get colon cancer from alcohol? These are risk factors. They all contribute. So the cause of cancer generally is multifactorial. So just picture it like this: every day, every one of us who is giving birth to, we have in each cell have 2 pairs of genes. Some people get when they get delivered, that one of the genes already mutated, and you're just needing one of these risk factors that she enumerated to mutate the next gene, and then all of a sudden, now you start on the path of developing cancer. You want to know why? Okay, you have you're talking about obesity leading to colon cancer. You see, just realize that as you get bigger in size, your body stores excess food as fat in the periphery. Now realize that in that periphery, there are some enzymes that will and hormones that will convert that fat and start working like estrogen-like factors. And estrogen is a stimulant for breast growth. And so because of that, those hormones start stimulating. And one of these cells, any of the cells, can just take off from that, get stimulated, and just leave the pack. And what we're talking about cancer essentially is any cell that has become a rebel, no longer controlled by the central command to regulate their growth. And then they keep growing and growing, like Lynn said. So alcohol, cigarette smoking, all these, there are triggers that may affect mutation of that second gene that would lead you to developing that cancer. So that's why we're telling you to try to live a more healthy lifestyle.
So I'm going to take some questions from the chat now. There's a couple of questions. One of them is, I'm going to lead this question to Dr. Erin King-Mullen. One is, what are the preps for colorectal cancer screening? Can you kind of shed a little light on the different types of preps? She's muted still.
Sorry, I'm unmuted now, sorry. So PrEP is short for preparation, right? And so the colonoscopy is a procedure. And so anytime you have a procedure, you're going to prepare for it in some way, shape, or form. Some of that preparation has to start actually as far out as 1 week in advance, based upon what diet you may be on, any certain medications. So you have to make sure you check with your provider on any changes in the medications that you need leading up to the procedure. More specifically, the preparation for the colonoscopy is we have to clean out the colon so we can see those really small polyps. And so the day before the procedure, you're going to be semi-fasting, so no solid foods, clear liquids all day. So anything you can see through, jellos, juices, broths, popsicles, those things. And there are quite the variety of different preps. A lot of them are based upon your provider's preference, what they've had good experiences with, but also sometimes medical conditions or prior surgeries you may have had may change which prep is recommended for you. Some are over the counter compilation of medications, and some of them are prescribed. And so you will be given those explicit directions by your provider, your surgeon or your gastroenterologist who will be performing the procedure will tell you the prep. And again, that is designed so we can see that lining of the colon really well, because that helps us extend the frequency with which you need a colonoscopy so we can be ensured that we've seen the colon adequately, and that we can limit missing very small lesions. And so, for example, if you have a nice clean colon, we can see well, and you don't have any other major family history or personal history or risk factors, then your next colonoscopy may not be for another 7 to 10 years. So that is, again, why doing that prep as instructed is extremely important.
So please, okay, go ahead, Lynn, but tell me, what are some of the excuses about this bowel prep? I mean, because, we're all here, and I want to hear from each one of you.
Yeah, go ahead, Lynn.
Excuses of the bowel prep. I just wanted to emphasize some of the things that Dr. King-Mullen said in terms of the prep. We have new and improved preps, because a lot of times people think of preps and they get scared. And I don't want you to get scared. We have what we call split dosing preps that are FDA approved. Split dosing means that you take half the prep around 5 or 6 o'clock p.m. and then you take the other half of the prep somewhere in the morning around maybe midnight or 1 o'clock. What that allows is for you to, number one, work. So you don't have to take off 2 days now. You can take off 1 day. You just stay on clears. And while you're on those clears, it's important to make sure you take a lot of clears, because some people just take the prep. You cannot just take the prep. You must flush your body with clears. So that's one thing that's going to allow you to be able to work. You don't have to take the day off, and you flush with clears. The other thing that's important for people to understand, we now have pills. So if you don't want to drink the prep, you can take pills. It's a certain amount of pills, but there's a wide variety. And the key factor that I want people to understand is prepping now is easier. And there is a prep out there that is tailored for you, for your lifestyle, and for what you need to do. And making sure that you are off any anticoagulation per your doctor's orders is going to be important. And that means aspirin, heparin, Coumadin, Plavix, all of the new blood thinners that are out there. You may have to stay on your 81 milligrams of aspirin, but all that will be done by your primary care physician first before you get clearance for your colonoscopy. So don't be afraid of the prep.
All right, let's go back to Erin, and Dr. Ofikpo, I'll come back to you in a second. Erin, walk us through how the colonoscopy is done, because a lot of people are afraid of it still.
And the funny part is actually after the prep and people being scared about the prep, a lot of times people are more afraid of the sedation or the anesthesia part of it, especially if they're relatively healthy and they're like, I've never been sick, I've never been under. Um, and so again, this is a very safe procedure. I want you all to understand that. And a lot of times the stories that you hear are those bad experiences because that's what gets highlighted, right? And that doesn't really highlight the thousands and thousands of colonoscopies that go on across the country every single day. But the procedure, you arrive at your facility, and it's pretty much standardized now. There may be a few places that don't really have the anesthesia team that are a part of the procedure, but once you arrive to the facility, the nursing team will place an IV. You'll talk to the anesthesia team, and you will be placed under IV sedation, monitored anesthesia care, twilight. These are some of the terms that you may hear thrown about, but you're just basically placed into a really, really deep dream, la la land state. You can pick whatever island you want to be on during the procedure. So it's not general anesthesia. You're breathing on your own with just a little oxygen in your nose. You are closely monitored. Okay. So your vital signs are taken very frequently to understand your level of stability during the procedure. While you're in that sedated state, we take a special instrument called the colonoscope. It's a long camera that's inserted. The width of it is about the size of my thumb. Gets inserted into the rectum, and we literally look around the entire colon all the way over to where the small intestine meets the colon, and we're looking for those polyps. And if we and that's the other added benefit again to the colonoscopy, is that it's both diagnostic, meaning you can find things, but also therapeutic. If you find things, you can treat them. So remove the polyp, ablate the polyp, and do a biopsy to understand what exactly we have found. Once you wake up from the procedure, you'll be monitored for a few more minutes to make sure you're passing gas, because air is inserted and instilled in the colon to distend it so we can see the wall and the lining better. So once you're able to pass gas, we know you're not in any pain and your vital signs look good, then you can go off and have lunch, brunch, or whatever it is that you have. But you do need a driver if you get that sedation medicine, because we do need to make sure that you get home safely. You take it easy that day, and then the following day you can return to full activity. And as far as for resuming any prior medications, again, explicit instructions will be provided to you upon your leaving the facility to understand, what you can resume and when.
Thank you so much, Dr. Aaron. Dr. Ofipo, you mentioned that you do not have to have symptoms before you get screened. Then why should people, go for colonoscopy instead of other screening methodologies?
Well, so just like Erin said, there are some polyps or lesions that are so tiny that we have access to visualize with the colonoscopy, especially with a good bowel prep, that even before they get picked up, for instance, a 1 millimeter, 2 millimeter, even a 1 centimeter polyp may not bleed for you to see any blood in your stool, may not cause any obstruction. So you may not even cause a change in bowel habit. So you'll be going around symptom free. Meanwhile, you're already carrying a cancer within you. And the other emphasis is that at that 1 centimeter polyp, we're talking about the probability of metastasis into lymphatics within the surface of what that polyp is sitting under. So that's an increased risk. And though other tests are based on products, for instance, DNA testing like Colorectal tests are based on the cancer cells shedding into stool, or a polyp being large enough to shed into stools. Then the occult blood testing is based on blood actually being in your stool. So we're talking about cancer cells, cancer sizes that are maybe very small to produce any kind of byproduct that can be positive in your testing. If you do a good bowel prep with good colonoscopy visualization, you can pick those and take them. You just nip them in the bud before they get a chance to grow into anything. That's the reason why colonoscopy is very important. Also, people who are very high risk for cancer, colonoscopy, there are some patients that have inflammatory bowel disease. There's something we call dysplasia, just high-grade dysplasia and all. You see the lesion, they are not cancer yet, but they're just a marker for cancer that may be existing in other parts of the colon. And so you can do a lot with colonoscopy. The other big advantage of the colonoscopy is that while you're there, you can treat it, what you see. The other tests, when you do them and there's an indication that there's a possibility of cancer, you have to go back to do a colonoscopy. So the advantage of doing a colonoscopy is that you can visualize it, you can see very small polyps, and right there and there you can nip it in the bud. You don't have to wait to go to see somebody else to do it. You're treated right there and there, and you're done with it. And based on number of polyps, you're already given a schedule on how often to come back to repeat your colonoscopy, and they are monitoring you. So that's why I think colonoscopy
There's
trumps.
there's another question, and this is gonna go to Dr. Erin King, actually Dr. Lynn O'Connor. Dr. Lynn O'Connor, can you differentiate what is the difference between screening and diagnostic colonoscopy? Because a lot of people still don't understand what that means.
Well, a screening colonoscopy and a diagnostic colonoscopy have to do with your risk. We're always talking about your risk factors. So there are certain risk groups that we talk about. A screening colonoscopy is for someone who is average risk. And average risk is someone who's age 45 years of age. We drop the screening age from 50 to 45 so we can catch that catchment of young patients who may be having increased risk of colon cancer. So screening is for someone who is average risk and they have no symptoms. They have no bleeding, they have no pain, they have no change in bowel habits, they have no constipation, and they don't have a family history of colon cancer, colon polyps, or any inflammatory bowel disease or genetic issues. This is someone who is average risk, 45 years of age, you get your screening colonoscopy. Sometimes when we talk about a diagnostic colonoscopy, that is a colonoscopy that is done when there are some issues and we are trying to diagnose whether or not there is a problem or if there is a cancer. And those are people who may be presenting with the change in bowel habits. They used to go regularly and now they're constipated and they can't go at all. They are now seeing blood more and more every day. They've lost 20 pounds over the last month. They have no further appetite, and that means they get full early, which is called early satiety. And then there's a third category, which is surveillance colonoscopy. And surveillance colonoscopy is for colonoscopies for people who have had polyps or cancer in the past. And we go in there and we surveil to make sure that there are no further issues. So that nomenclature sometimes gets interchanged, but that's the exact meaning for them.
That was a good answer. That was a very good answer. So let me switch gears a little bit. Rectal bleeding, Dr. King Mullins. What advice do you have for young people, especially? And obviously, the most common complaint is, oh, my hemorrhoid is bleeding. When a patient, let's say a 32-year-old has bleeding hemorrhoids or quote unquote bleeding hemorrhoids, what advice would you give them as a colorectal surgeon?
So the number one answer is to be evaluated. It may be nothing, but it may be something. And not to, make our listeners afraid, but the actual highest risk category that we're seeing, or the age range with the highest incidence of specifically rectal cancer that we're seeing these days, is actually from age 20 to 39. 20 to 39. Okay. So that is even younger than that 45-year-old that we have decreased the screening age to. So what I tell people is, at least have the conversation with a trained provider. So it could be a colorectal surgeon, your primary care physician, a gastroenterologist. But so we can walk you through some things and answer some questions. If you saw blood once because you were straining, you were really constipated, it was a flash of bright red blood and you had a little pain or something and it just never returned, then we can evaluate you. And I tell patients all the time, like, hey, not to be gross or anything about it, but I see butts all day, every day, right? I see hemorrhoids and colons all day, every day. And so when I listen to your story and I perform an examination, if I'm looking at the hemorrhoid area and I don't think what my examination shows is matching what your story shows for the amount and type of blood, then I'm going to say, hey, maybe we need to do something a little bit more investigative. It may not mean that you need a full colonoscopy. It may be an anoscopy, okay, using a small speculum to look more internally in the office, or a flexible sigmoidoscopy or a rigid sigmoidoscopy, which is like a partial colonoscopy to look at that last part of the colon. Because again, typically, unless you're really bleeding out heavily a lot, bright red blood is typically going to come from that last portion of the colon. So either the hemorrhoid area, or there can be things, what we call our diverticula, a little bit higher up, or inflammation. Those are age ranges that you can see uh, people being diagnosed with Crohn's disease or ulcerative colitis. And so having that evaluation and examination can put certain things on the table or take things off the table. And then also, even if there's pain or other symptoms associated with it, there are other things that can go on in the rectal area that are benign, okay, non-cancerous, that may need treatment. So there's fissures, there's fistulas. Again, if you have inflammatory bowel disease that's presenting as something that may present as bleeding, again, it may not be cancer, but it still may need some sort of, formal treatment and therapy for it.
All right. So, I think we mentioned polyps quite a bit. So we all know that most colorectal cancers arise from polyps, and 30% of adults under the age of 50 have polyps, and 40% of patients have multiple polyps. The question is because I always ask people, are you polyp free? But people always ask, are all polyps eventually going to become cancerous? Dr. Erin Kingdom, what do you think about that?
No, and that's why it's important to at least get that initial screening baseline examination so that, if something is seen abnormal as a polyp, we can do those biopsies and send them off to the lab so they can look under the microscope so they can tell us specifically what type of polyp there is. Some polyps are more aggressive than others. And so the baseline polyps that we know eventually grow and turn into cancer are called adenomas, but there's different types. There's serrated adenomas, there's villous adenomas, there's tubular adenomas. That's a lot of medical speak, but the risk of cancer with each one of them are very different. And so, for example, a serrated adenoma, even though it may be found as very small, tends to grow into cancer at a slightly faster rate than, say, a tubular adenoma. And so the recommendation for your next colonoscopy for a serrated adenoma would be 3 years, whereas for a tubular adenoma, it will be 5 years. Now, there's some other risk factors that go into that as well. How many polyps are found, if there's any dysplasia or precancerous change, the size of them. So there's lots of information that goes into, making that determination on the frequency or that surveillance colonoscopy that Dr. O'Connor mentioned. And so that's why it's just very important for number one to get that initial baseline evaluation so we know, you know, what your body is like.
So we talk so much about risk factors, and one risk factor that we didn't really mention quite a bit is beef. So what's the beef, Dr. Erin? I'm sorry, Dr. Connor. What's the beef here? Can you take a stab at that?
Where's the beef and what's the beef? Well, when you're talking about beef, and most likely a lot of it has to do with the barbecued and charbroiled foods as well too, because they have nitrosamines. And nitrosamines were thought to have affecting the lining of the colon. And when it affects the lining of the colon, then those are they are thought to be carcinogenic. So, and the other thing that's important as well too is that when you have a diet that is high fruits, high vegetables, Mediterranean diet, your stool moves through the colon at an efficient manner. But when you're having foods that are high fat, the beefs, the nitrosamines, the cured meats, the preservatives, that type of food tends to stay in the colon. And the longer it stays in the colon and you have those carcinogens, the longer it interacts with the lining of the colon, the colonic mucosa. And that's where you're looking at the carcinogens and the carcinogenic effect. So you want to make sure that your diet is not full of that. You want to have an increase, you want to have a normal transit time, and you don't want to have foods that are going to weigh you down, that are going to cause constipation, and that's going to allow the bacteria there to work on it even longer and break those foods down. And the other thing is important is there's certain foods that feed the lining of the colon. And I don't want to get too scientific, but those foods that break down when you have a good high fiber diet are the ones that actually help feed and nourish the lining of the colon. So you want to stay away from the beefs and the nitrosamines. And as I said before, everything in moderation. If you're going out, you're celebrating, going to a steakhouse, have that steak if you want, but something on a regular daily basis.
And why don't we switch gears a little bit and talk about, somebody have a hands raised earlier, but let's go back to the questions from the audience. So are there, let me rephrase that. So, so someone says, I don't have a family history of colorectal cancer. Am I still at risk? I know we've covered that, but that's a question that just came up.
Yes, I mean, as long as you have a colon, you have a risk for colon cancer. So we're all at risk, and the greatest risk factor is age. So as long as you're going to grow older, your risk, I mean, you have a risk for colon cancer. So usually, initially, why we started age 50, because people, the incidence rate of colon cancer in people age 50 and above was very high compared to younger folks. And so we ramped up screening for that age group starting age 50. And then we realized that even people with colon cancer, we started seeing people with colon cancer at a younger age. And just like Dr. Erin King Mullins said earlier, our greatest problem right now, what we're seeing all over the country, is incidence of colon cancer in young patients. And the problem right now is you have their parents sitting there when you're diagnosing them. They have no family history of colon cancer. Parents are okay, but their kids are having the problem, especially rectal cancer. And so the risk for colon cancer is grave. And at this point, we can't say for certain why we see this high incidence in younger people. We're attributing it to possibly due to food, and not just the food, but the preservatives in the food. Right now, people move around, we're very fast paced. And so most of our foods are packaged. Now, what are they using to preserve those foods? So yes, whether you have family history or not, you're at a risk of developing colon cancer. Come to think of it, colon cancer associated with a family is only about 5%. Most of the colon cancer we see are not because of family history. So yes, please get your screening done.
So we are nearing the last leg of this open forum, and there's still, I think, one more question as it's coming in. I would like to have our esteemed panelists begin to give their parting words on anybody who's still sitting on the fence about getting a colonoscopy or still don't understand what colorectal cancer is or what it should do. Go ahead and give you a 1-minute spiel on what you think is a parting word here for them. Let's start with Dr. Lynn O'Connor.
Thank you. Dr. Amajoy. I think the most important thing that people need to understand is screening saves lives. And, I always tell people the best screening test is the one that's done. If you cannot get to a colonoscopy, do your fecal occult blood test, do your fecal immunochemical test, do the Cologuard, do something. The colonoscopy is the gold standard. That is the one that is both diagnostic and therapeutic, and that is the one that we recommend. But the best screening test is the one that's done. Secondly, if you are going to get a colonoscopy, help yourself. Do the prep properly, do the clean out properly. We will see if you've eaten, we will know if there is food there, and it will only mean that there are polyps that we cannot see. Thirdly, that's important, is know yourself, know your habits, turn around and take a look at what comes out of your body. Understand your habits. And the fourth thing is talk to your family. We're a smaller family now. We need to make sure that we know what mom had, what dad had, our brothers and sisters, our uncles, our parents, our grandparents. Talk to your family, know your family history. And when you go get your colonoscopy, bring somebody with you. Share this information. We have a unique opportunity where we can each teach someone else. We can each bring someone along. We can share this information, and together we can eradicate, prevent, and cure colon cancer.
Great. That one question just finally came in before I have Erin and Ofipo comment, but we didn't talk about smoking that much. As we all know, smoking is, even though most of us here don't even smoke, and we tend to forget that the general public still smokes. 20% of adults are current smokers and 50% of high school students are smokers. Dr. Ofipo, you want to take a stab on that?
Yeah, so we recognize that cigarette smoking is a risk factor for not just colon cancer, but for myriads of cancers. Initially, the cigarette, if you take the cigarette and you analyze its content, all the carcinogens that are present in them affect the gene to get to that level where you get mutation, and then this mutation drives that process of the cells forming cancer. And this applies to not just colon cancer, but myriads of it. Now, when you do talk about lung cancer, there's some local effect. So you understand that this local effect of that cigarette smoking and the systemic effect of that cigarette smoking. The local effect of this cigarette smoking will affect the lungs where it's gone, including the systemic effect of the carcinogens found in the cigarette smoke. But for colon cancer, we're talking more of the systemic effect of that cigarette smoking. The things that you inhale goes into your blood and cause the triggering. Same thing with alcohol. So the greatest advice one can give is drop the habit. You'll be better off without the cigarette than with it.
What about secondhand smoking? They also want to know about that.
Yeah, secondhand smoking is the same as the primary person smoking. If you're locked up or you're in an environment where somebody's smoking every day, you are inhaling the same amount of smoke the person is inhaling, let's put it that way, without the gratification of being a smoker. Yeah, so that is even worse. So you may have a partner who smokes. It's in your interest to persuade your partner, advise them whatever you can for them to stop smoking, because you are the greatest loser with a partner who is smoking. I don't mean it in that fashion. I just mean it that you have a lot to lose when your partner is smoking. Well, because at least he has a calculated risk and probably knows the risk, but chose that lifestyle. But you probably made a decision not to smoke because of the effect of cancer coming out of it. But being with a person smoking around you puts you at the same risk almost the same risk with the person who smoke. So everything I said about the person who smoke goes to the secondhand smoker.
Very good. So, Dr. King Mullins, we're going to wrap this up, and I want you to go ahead and give us a nice commentary and advice for this audience on colorectal cancer.
Thank you so much, and I've enjoyed everyone here today. So my two biggest pieces of advice is number one, the number one risk factor is age, okay? Only about 10 to 15% of colorectal cancers are actually linked to family history, so that's why the screening age has been lowered. That's number one risk factor. Number two, the number one tool that we have, just like Dr. O'Connor mentioned, is to get screened in any sort of way. But I would say even further than that is to have those discussions with family. I know I just made the comment that, oh, only 10 to 15%, excuse me, are associated with a family history, but that family history is additive, okay? So once you start reaching a certain age, and then there's the compounded effect of family history of not only colorectal cancer, but also a family history of polyps, we need to get screened earlier and more frequently. So talk to your family and talk to your providers and stay vigilant.
All right. Dr. Fiku.
Yes, I want to use this opportunity to focus on the young folks who are younger than 45 years old, who are less than the age for national recommended screening age. In my practice, I am seeing more and more young folks from age 20 to 40 with aggressive colon and rectal cancer. These young age patients that I see, most of them come to me, referred to me for hemorrhoids. And once you screen them, then you discover they have cancer. But it's not just cancer, an aggressive form of cancer. We don't have an explanation to it as to why this sudden surge over the last 5 to 10 years started and has progressed. And so I want to emphasize this to this age group and to caution them. Be careful with the diagnosis of hemorrhoids. You have to also question what you eat. Try as much as possible to have cooked homemade foods. If you can't, just read the preservatives. Stay away from a lot of preservatives. We really do not have an answer to this, but our go-to point is diet and exercise and living a healthy lifestyle. There's so many things going around, cigarette smoking, all kinds of things that people smoke and put in their bodies. Just have a high index of suspicion if you're in this age group. Don't say you are too young to have colon cancer. This is not meant to scare people. It's just meant to raise their awareness based on what we're seeing. And it is not just me saying that. In a national conference, almost everybody is seeing the same pattern. So it is very important for the younger age group, because you don't meet certain criteria that triggers follow-ups. You have to advocate for yourself to say, hey, I know it may be hemorrhoids, but can we do more? Thank you.
So thank you so much, guys. I think one big takeaway from this is the knowledge that polyps are very common, but colorectal cancer is not that common. So we're really screening for polyps. So I always ask my patients, ask everybody I meet, are you polyp free? Do you know if you don't have any polyps yet? So the chances of finding cancer is a lot less than finding polyps. So you do want to remove the polyps before they become cancerous. So today you've basically heard from these three esteemed colorectal surgeons, and I've heard the advices. And colorectal cancer is very preventable. The age is 45. Once again, it is 45. That changed 3 years ago. It's no longer 50. It is 45. Colonoscopy is available everywhere. It's in your backyard. I have people I'm from Nigeria originally. I have people come from outside of America to come here to get screened. So if you do have it in your backyard, there's really no excuses. For more information and for more, Dr. Lynn O'Connor actually is going to be on Good Morning America. That's Tuesday at 7:15 a.m. and also in NBC News Now, and that's at 1 p.m. On Tuesday. Am I correct, Doctor?
They're switched. NBC News Now will be at 7:15, and Good Morning America, third hour, 1 o'clock.
1 o'clock. Okay. Thank you very much for that. Again, thank you so much for coming and joining us. Have a wonderful day.
Thank you. Bye.